So I wanted to thank everybody for coming to the digital education series that the NCVH has put together. I wanted to thank in particular Dr. Craig Walker and Tom and his whole crew for putting this together. It is unusual times, but I think this is a great methodology, and I think we're going to be able to have a little fun together and learn a little bit about a novel methodology for pre-screening and identifying venous patients. I'm Dr. Ari Soffer. I'm a board-certified cardiovascular specialist in the Aventura area in South Florida. And let's get started. So my pertinent disclosures are as follows. USA Therm, I'm both a co-founder and heavily involved. Juzo, I'm an ongoing consultant and a co-founder of RX Photo clinical photography tool, as well as chairman of the Vein Forum for the NCVH. Let me go over some rudimentary basics. This is never the most fun part of any talk, so we're going to build positively from here, but I will tell you that a few things about thermal imaging. It's based on the emission of heat energy that really emanates from all objects above absolute zero, which is, minus 273 degrees. It is part of the electromagnetic spectrum, which I'm going to show you in the next slide, which gets a little more colorful. The heat that's emitted varies with temperature and the emissivity. So there's two things that are involved in seeing heat emission, the temperature itself, as well as how well it's reflected off something, with one being an optimal number, and interestingly, the skin having about a 0.97 emissivity ratio. So emissivity is important. It was first discovered by an American astronomer in 1878 named Pierpoint, who was able to detect the temperature of faraway objects, such as stars and planets and cows in those days. Originally, we were only able to detect one spot, but then once multiple measurements started to be done, we started creating a heat map. And if the energy can be focused on a bunch of those multiple points, well, and they're measured simultaneously, a heat map can be created that is basically analogous to a photograph. So it's something that we're used to seeing. This is not really infrared imaging as we would see in night vision or night vision cameras, as we see frequently, which measure reflected infrared light close to visible light. But, and I'll show you on the next slide, as you can see here, the visible spectrum is what we kind of see with our eyes. At about 1, we can actually see the near infrared night vision, and at about 10-fold more, we see thermal imaging, and that's what we're focusing on, which is different than obviously radio on the extreme right and gamma rays on the extreme left. So it's kind of a longer wavelength, lower frequency, lower energy than, say, visible light. That's thermal imaging. So modern thermal imaging, until recently, were very difficult to attain. These images. They were large, or expensive, relatively poor definition. And as with almost all electronics, they began to get smaller, and obviously thermal imaging was no exception to it. Cameras have gotten smaller and smaller and cheaper, and they actually are having even more definition while doing that. So it's been a terrific time over the last 3 years for thermal imaging. Germanium and sapphire lenses are the lenses that actually are focusing the emitted heat onto a sensor array, and that creates these virtual maps. As you can see, my hand optically, but on the slide here, you can see my hand with the Apple Watch and the metal from my ring, which emits at different levels than, say, the skin or the blood flow underneath the skin, and the clear lines that are different between, say, my skin and a keyboard. So these are creating a visual map and then turning them into different colors that make us be able to see something that we recognize. So thermography in medicine has been a recent evolution, and in any condition when there's a change in temperature, medical condition, there's a predictable change related to the disease. Now, inflammation, arthritis would be something obvious that could heat up. Breast disease, a cyst, say, versus a tumor. Peripheral artery disease are obvious. Many other applications that exist. However, the landmines exist as well. And what do I mean by landmines? Well, thermography seemed to get its first interest, at least medically, within the looking for breast cancer. And unfortunately, with breast screening, which was initially tried to be done, there is this great thing where we can see here on the slide where you have normal breasts, and then you have an abnormal image suggesting a cancerous breast, which it actually was, which is a wonderful thing to pick up, particularly if it had not been known before. And it got a lot of early use, but did not have the sensitivity and specificity to be a great test, because breast tissue is by definition tissue, and there can be a lot of it, and that can make the emissivity a problem, and therefore there can be false negatives, and you really can't have that when you're detecting something like cancer. So the FDA made a decision in 2017, after seeing a lot more of this and growth in the industry, that this was not probably something that we should be using alone, but we can use it adjunctively with more common breast imaging techniques such as mammography and so forth. Venous insufficiency is the ideal pathology for clinical thermography, and I'll explain why. The unique situation is that when valves reflux, particularly when standing, blood flow from the deep system, the core system, which tends to be a few degrees higher than the superficial system, tends to eke out or leak out. Deep blood is hot, and when it goes into the surface of vessels such as varicose veins, it makes a great demarcation between that and the skin, that it's cooled by the surroundings and evaporation. So this large and consistent temperature difference we were able to exploit, and we could see that there was a real difference between veins that were leaking core blood or venous insufficiency and those that were not. Those were just veins that happened to be visible but were not leaking in any way, shape, or form. So this was a really cool development. You cannot see, however, trunk veins, so duplex ultrasound is still essential, and we still recommend it on all patients. It's very quick, straightforward, and only shows really insufficient veins, different from some of the other sort of vein techniques that are out there to maybe help with IVs and so forth. They don't show the difference between venous insufficiency and not. That's a pure function of temperature, and only checking in the thermal ranges will we be able to see such insufficient veins. Here's a sort of a cartoon adaptation of what I'm saying. So on this side, we actually see a deep vein, which is this would be the inside of the leg, and you see the perforators giving blood from the skin, or the cooler veins, indicated by the sort of, the cooler blue, and that goes towards the deeper vein, which then of course goes towards the central system and to the heart. In a normal vein, we have that set up similar to what I just showed. This is on the sort of the outside to the inside in the deep veins. However, in a failed valve, a leaky valve, a valve that is putting pressure coming towards the deep to the superficial, you can see how everything gets heated up in a varicosity or any superficial vein in a failed valve. This is the first pictures that we started seeing when we started looking at it, and you can see the images were very clear, very exciting. Between this is a GSV pattern. This happens to be just an unusual pattern that we saw. These are some of the first pictures that we took. This is more specific to the GSV. So here we have a GSV that was known to be insufficient, mostly because the patient, as you can kind of lightly see here, but you can see the skin changes, so chronic venous stasis changes suggested for venous insufficiency. This patient was known to have venous insufficiency, but then the vein, which is not visible to the naked eye, was very clear and had some tributaries we were not even aware of, so it helped us substantially in mapping this particular patient in the greater saphenous region. Similarly, in the smaller saphenous region, another patient that had really no visible veins optically on either side, but under thermography showed tremendous venous insufficiency that was corroborated by ultrasound on both legs. So the small saphenous lights up very clearly. Some of you may be already saying, well, what are these things at the folds? And that's the subject of the next thing, which is what are some of the false positives. And an area like this woman happened to be sitting, she happened to be skin on skin, causing this area to heat up. And we see that in the knee folds, as well as one or two other areas, which after a while become very clear to us. The linear pattern here and here are, in this case, tributaries of the small saphenous, if not partly the small saphenous. And this area is actually heated for another reason, and it's very easily, after a period of time, small time of experience, to differentiate the two types. So these other areas of potential artifact include the anterior tuberosity and anterior tibial area in general is a very capillary rich and a very vein rich area. Basically, it's middle of the bone and there's no skin and typically no fat over that area. So sometimes we do see a pattern that looks like this, which is not a vein, different from this linear vein that was seen, but this is actually a very common artifact that we know how to differentiate from. And one of the more interesting pictures where certain other things come up with different temperatures and for different reasons, depending on the type of camera and imaging you're using. So this was a poster presentation that we gave at the Vein Forum, the AVLS. We've done this a number of times. Very, very illustrative. These are two athletic legs. One athletic leg is here with a very prominent vein that sets about the same temperature. Under thermography, it is also a uniform color. This one has some veins in it that you can see it as well, but the temperature difference is about 3 degrees, which is typical for insufficiency. And sure enough, thermographically comes very clearly as a linear vein that met with ultrasound corroboration. And I know this for a fact because this is my leg, and this is my associate, the co-founder of much of what we're doing here, Dr. Wright, that actually is 10 years older than me, but has no venous insufficiency. Both of us consider ourselves athletes. He apparently is maybe a bit better in the sense that he does not have any venous insufficiency. But an interesting comparison how one picks up and the other that doesn't have insufficiency is clearly quiet. So this is also extremely useful to use as a patient educational tool. This is on an iPad that we constantly use in our offices, and we're able to show patients their areas that they may or may not see and actually show them along the way areas of improvement. There's no visual comparison to this. Even the actual optical pictures are not as understandable as when we show thermographic pictures. It is, most patients say it is absolutely illustrative to them, where they, in other pictures, whether they were ultrasound or even optically, where maybe they didn't even have visible varicosities, they didn't understand as well. So it's a wonderful educational tool. It's in these days, obviously in 2020 at the taping here, the end of the summer 2020, non-contact's a big deal. Obviously we can see this from many feet away, and we can have no radiation emitted whatsoever. In fact, we're only capturing radiation, zero emissions. We're actually capturing just the temperature radiation that's coming off of the human. And it's been a nice thing for pre-screening. This is someone coming into one of our offices. We use it really in this case just illustrative. We're just drawing attention to it right now, as we've not commercialized this, but it was an interesting thing that we added to some of our offices with just a lot of interest. ThermPix is the name of the software that does this. It's a HIPAA-compliant, cloud-based organizational software platform that captures all these pictures, puts them into the proper categories, meaning medial thigh, lateral calf, what have you, and allows us then to use it as cataloging and comparison for future data acquisition, whether they be research or just showing patients or their insurance companies progress. This has been a project with us and the compression sock company Juzo, the international compression sock company Juzo, which has been able to see the future with us. So the R&D that's coming in the future with venous thermography is very imminent, meaning we're going to start giving our data. We've already given our data to publications, and those will be published in the next quarter or so, which includes our sensitivity and specificity reporting, which is absolutely substantial. We used a third-party biostatistician to analyze it from a local medical school. There were no false negatives, which is very helpful in screening tools. You don't want anyone to walk away with something that we might have missed. And the sensitivity was greater than 95% as well. So a very, very interesting a study that will be coming out in the vascular journals in the very near future. We're also showing a comparative study showing a group of 100 patients that had thermography and a group of 100 that did not have thermography between 2 years. So in 2017, 2019, using the same personnel, the same way of doing things. And we found about a 25% increase in clinically relevant insufficient truncal veins. In this case, many of them went on to ongoing ICAVAL, AVLS appropriate procedures on those patients that otherwise might have been missed. Patient satisfaction results were pretty much through the roof for us. And we are looking at machine learning and artificial intelligence mechanisms to be able to do this on an ongoing basis a little more consistently. So in summary, thermal imaging is now handheld, mobile, and soon will be widely available and affordable. And by soon, we're looking at 2021. There is varicose vein disease that sets up a unique predictable temperature difference, which makes for what I call the leading edge of the spear, meaning we're going to learn so much in thermography, but varicose veins are so perfectly designed to use this without really much false negativity, or for that matter, false positivity. So it's a very good disease platform to understand thermal imaging. Pre-screening legs with thermal imaging gives a near immediate indication of an abnormality that could create a very highly specific varicose vein map that could then be further mapped with ultrasound. And then the sensitivity and specificity data, as mentioned, will soon be out there and give everybody even more comfort regarding that. The comparison data is also being published in a separate journal, maybe a bit before. Both of these will be in peer-reviewed journals published shortly and presented at a few of our meetings. Ultrasound techs, interestingly enough, have ubiquitously reported significantly reduced scanning times. We see an increase in efficiency of about 33% less time to full completion of a mapped leg vein or veins that was at least as good, if not better, than before. So for those of you that have an interest, you can contact the USA Therm folks for potential early adopter and research opportunities. They are adding those. There are some research opportunities and early adopter capacities. It is not available commercially just yet, but we are looking at 2021 for a very interesting potential worldwide rollout. So thank you all for your time. Thank you to Dr. Walker and Tom Best for putting all of this together, and thank everybody for their attention.